Good day. This is Sleep Health, presentation of sleep health during the COVID-19 pandemic. This is the first in a series of webinars that Sleep Health, in collaboration with Elsevier and with the support of the Journal of the National Sleep Foundation, will be presenting on a regular basis with our top recent papers of keen interest. Today we have a series of excellent papers. I'm Orfeu Buxton, the moderator and editor-in-chief of Sleep Health, and we have 4 presenters with recent publications in Sleep Health that reflect on the COVID era. Those 3 papers are available free for download at sleephealthjournal.org. You can also see instructions to authors there. The first paper from Dr. Yuksel, Baker, and colleagues addresses the sleep health issues around the country, around the world in 59 countries related to COVID-19. Dr. Grandner will be presenting the second paper, a more fine-grained and longitudinal analysis in the US using wearable sensors for estimation of sleep. And then Dr. Coiro will be talking about sleep quality in COVID-19 related stress in the US and Israel. We will be having short summary presentations from each presenter, followed by a question and answer period. Please see the chat or question feature on the right side of your BrightTalk screen to address the questions, and I will bring them forward to the presenters. So without further ado, Dr. Yuksel will be presenting first. She's a postdoctoral fellow working with Fiona Baker in the Human Sleep Research Program in the Center for Health Sciences at SRI International.
Okay, yeah, thanks a lot for the introduction. My name is Dilara. Today I will talk about how sleep health was impacted among the population on a global level. And Fiona Baker, the senior author of this paper, will join and will be mainly involved in the discussion later. Okay, so in our study, we wanted to investigate the correlates of sleep health, and our study is a survey study to enhance global participation. We collected our data in the early to mid stages of the pandemic between late April and early May 2020. So here you can see all the countries that participated in this study. We actually translated our study into different languages, including English, Spanish, French, German, and Turkish. And this is how we were able to engage more than 6,500 participants, as you can see here, across 59 countries. So let's take a super quick look at the sociodemographics here. Most of our participants were females, had no dependents at home, and had an active employment status, and approximately half of the sample was married or in a domestic relationship. So these were our measures. Besides measuring sleep behavior and sleep health, we also collected data on the psychological distress during the pandemic, including depression, anxiety, and stress symptoms. And of course, we collected data on the demographic characteristics, the COVID-19 exposure, quarantine and isolation measures, and the COVID-19 related lifestyle changes. Okay, so let's take a quick look at how sleep routines were affected compared to pre-pandemic times. We actually have some really interesting findings here, and I will just give you a super quick summary. More than 50% reported to go to bed and to wake up later or much later than usual. So this means we saw a shifting towards later bed and wake up times in our participants at that time. And about 30% of the participants reported sleeping less or much less than usual, while about 25% of them reported to actually sleep more or much more than usual. So this means we also saw some tendencies towards under or oversleeping. And interestingly, more than 35% reported more trouble or much more trouble falling asleep, or more or much more awakenings during the night compared to pre-pandemic times, which shows that the sleep quality was impacted as well in about 1/3 of the sample, actually. Yeah, in the next step, we conducted some regression analysis to find possible predictors of sleep health. And interestingly, we found that older age, living in a country with a higher income classification, and being partnered were protective factors for better sleep health during the pandemic. So these are all factors that are related to some kind of, life stability, which could be a reason for that. We did also look into the correlates of a poorer sleep health, of course, and we found some predictors of a poorer sleep health. And these factors included mostly the personal life changes due to the pandemic. For example, getting laid off from the job, having a hard time transitioning to working from home, or also being unable to get enough food or pay important bills, were associated to a poorer sleep health. And notably, the increases in verbal arguments at home emerged as the strongest predictor of a poorer sleep health. So this factor has been highlighted in other studies as well, and it has frequently been associated to negative outcomes, which means, special attention must be paid to this particular factor, the increases in verbal arguments. And besides, we also found that a stricter level of quarantine was also associated to a poorer sleep health here. So, of course, we also looked into the relationship between sleep and mood, and in line with literature, and as we actually expected, we found significant associations between a lower mood and a lower sleep health. And this, again, emphasizes the importance of sleep for maintaining a good mental health during the pandemic. To take advantage of the global sample, we also looked into the global differences, and on a global level, we found the lowest sleep health scores among participants from Latin America and the Caribbean area. So, after giving you a super short summary of our most important findings, let's talk about what this actually means. We saw that sleep is impacted on a global level during the COVID-19 pandemic, and most of the correlates of a poorer sleep health emerged from the personal COVID-19 related life changes. Also, we saw that, or our results showed the close connection between sleep and mood during the pandemic, which means that sleep could act as a protective or a risk factor for preserving mental health during major life stresses, like, for example, the COVID-19 pandemic. And I think all sleep researchers can agree to this sentence: healthy sleep is key to overall health. And luckily, sleep is a modifiable behavior that can be improved by implementing small daily changes or small routines, habits. For example, having a regular sleep schedule means setting regular sleep and wake up times, or and also maintaining them actually on weekdays, but also on weekend days. Avoiding under and oversleeping, increasing physical activity is great, in the best case outside, to also increase sunlight exposure, just to name a few. I'm sure we will talk about this later as well. And I'm just glad that sleep is getting some attention now that we are beginning to understand the impact of the pandemic. And I'm very happy that we can spread more knowledge on these strategies now. And with these words, I would like to close the presentation. I want to thank you for your attention, and also thank you to this amazing study team, which was international. You can see the different participating sites here. We are continuing our research. Feel free to participate, and if you have any questions, please reach out to us. Thank you very much.
Thank you, Dr. Yuksel. Are there questions from the audience? Please go to the question icon on the right of your Bright Talk I posted a few announcements during that for some of the questions. I think we have an audio issue with one of the mics, so it shouldn't be for all of the presentation because we'll mute mics in between. The presentation will be recorded and posted at theNSF.org afterwards. So the first question, did you look at the timing of subjects' sleep periods, so the sleep timing in this study?
What exactly?
As opposed to just duration or quality, the timing of sleep, was that addressed in your study?
Yeah, so we did look at the regular timings. So I think subjects slept an average of 7 hours per night, about that. So it wasn't really short or really long, but yeah. So
was it?
And I would add to that. I would add we also asked about their sleep in the duration of the pandemic compared to what it had been like before, and then we did see that on average, or in general, people did report going to bed later and sleeping later, so waking up later. And I think that makes sense to all of us, knowing how without the school schedules and the work schedules, then there was this change in sleep timing.
I certainly noticed that timing is either later or at least different for people than before the pandemic, and sometimes more regular, sometimes more chaotic, but very little the same is an impression. Do you have a sense of early, late, or regularity as well as just the timing?
Yes, we do. Do you want to go ahead, Dilara?
No, can you? I had an audio issue.
Okay. So we do see that with the RU Sated scale that we used, which does look at sort of sleep health, that does consider regularity, and we know that one of the factors we would say, I think maybe what the take-home message is that there's, on average, people were going to bed later and waking up later. There was more variability in how regular people were maintaining their sleep. And there's lots of individual variability in that you might think some people had more opportunity to sleep, but at the same time they were sleeping, the quality was worse. So there was about a third of the population that we studied who said that their sleep satisfaction and sleep quality was poorer than before. And I think those are the people that we'd be concerned about, because that's related to the worse mood measures. So some people slept better and slept more, but it's a problem for about a third of the population who did not.
Did you also have any measure of alcohol consumption in this study?
We did not look at that in this study.
It's certainly a popular topic. We may come back to that later. So some people are asking about the Latin American Caribbean locations. Curious about those results of the sleep score for Latin America and the Caribbean. Do you have any hypothesis on the cause?
Well, so the countries were in different stages of the pandemic. We don't have a specific hypothesis, but we did find some studies that reported a general lower sleep or more disturbances and more sleep problems among participants from that area. But yeah, there is no study, comparing all of these regions during non-pandemic times. So that's why we don't have a real baseline to compare it with.
And just adding to that, of course, because ours is cross-sectional survey, so we don't have a longitudinal. We did ask about the sleep beforehand, and so can say that, but we didn't, like Dilara says, we did not track changes in sleep health from before to during the pandemic. And also, like Dilara points out, our survey was done in April and early May, and so it was before the bigger impact that happened in Latin America later on in the year. So I think another point is that the sleep health and sleep quality, as well as the mood, could be worsening, across the duration of this pandemic.
So there are some more very good questions, but they would apply to all authors. So I want to save a couple more remaining for after. If we could now ask you both to mute your microphones. Thank you very much. and move to Dr. Grandner for the next presentation, please.
Great. Thank you very much. So our project was looking at changes in sleep duration, timing, and variability during the early months of the pandemic. This is data from large-scale Fitbit data from 6 major U.S. cities. I first want to acknowledge the co-author in this study was an awesome data scientist from Fitbit named Nagma Rezai. She did all of the analyses, and she generated actually these really awesome figures that you're about to see. So definitely want to acknowledge her for working on this with me. So this project was sort of a collaboration between our group at the university and Fitbit, looking through some of their data. We had a sample of over 150,000 active Fitbit users from these 6 cities: Chicago, Houston, LA, New York, San Francisco, and Miami. The thinking being that we have, especially in the beginning parts of the pandemic, we had New York, we had California, we had Florida, we have Texas, and we have the Midwest all sort of represented here. And we had a breakdown of age and gender groups, though the cell sizes aren't the same. That's just representing who the active Fitbit users are. First thing we noticed was 2020 was a departure. So here were the 12 months of the year for women and men. This is typical sleep duration. You can see the 2018 and 2019 historical data are pretty spot on each other. But then look what happened around starting in February to March of 2020, where there was this divergence of slightly increasing sleep duration in both men and women. I think this is pretty striking. Also, in terms of, this is variability. This is the standard deviation of sleep duration. And you can see, again, in men and women, in 2018 and 2019, you sort of see a pretty typical seasonal pattern. But then in 2020, something happened and the variability dropped. And you'll see what that means in a minute. I want to point out that sleep duration changed for a lot of people. So based on this tracking data, you can see here, sorry, that's a little small, but this is looking at the proportion of the population in women and in men across the different age groups for each one, going from 18 to 29 up to 65 plus. What proportion increased or decreased their habitual sleep duration? This is weekly average sleep duration. And you can see consistently about a third of the population did not change their sleep duration, but 2/3 did. And you can see here more people increase sleep duration, some people decrease their sleep duration. And you could see this age gradient where the younger you were, the more likely you were to increase your sleep duration, especially by at least 30 minutes. In terms of sleep timing, in general, people were going to bed later, but again, this was not universal. Another thing you can see here in terms of sleep timing, that between 25 and 38% of the population did not significantly advance or delay their sleep phase. Again, you can see here pretty consistently, maybe around 1 in 5 people started going to bed earlier than they did before, but most people were going to bed later than they were before. And again, you can see this age effect here, where younger people were delaying even more. When you look at the sleep duration changes by age, so you have February, sort of pre-lockdown, quarantine, pandemic era, and then you have March into April. What you see here in the 18 to 29-year-olds, you see not only a slight increase in the mean in sleep duration, you also see the flattening of the curve a little bit because you're increasing variability. So some people are sleeping more, some people are sleeping less. Whereas the 65 and up group, you can see it's only very slight changes. So you can see this age difference. Here's another way to display the changes in sleep duration by age group. And you can see January, February are sort of right on top of each other. Here's Monday through Friday. Here's people sleeping in on weekends. And what you can see here is this upward movement, except really here in the 65 plus year olds, this upward movement in amount of sleep. And you can see that this upward movement is occurring more during the week than on the weekends, where weekdays are starting to become closer to weekends, which is why you have this decreasing variability. the variability is capturing this difference, and the difference is narrowing. Where the 65 and up year olds, consistent with other epidemiologic data, they have a lot more control over their sleep anyway. So removing things like commute times and instituting things like working from home and things wasn't changing that group as much. This is the issue about staying up later. So not only were people sleeping longer, they were actually staying up later. So staying up later wasn't truncating sleep, it was shifting it. And you can see these shifts actually are consistent across all these different age groups, though they are larger in the younger, and I say younger with an asterisk because this isn't teenagers, this is people under 50 who are still advancing quite a bit. And you can see it's this progressive phase delay. One thing that was really interesting was that resting heart rate, as measured by the Fitbit device, changed. These were small changes, but they were different than what you would typically see. In looking at 2019 data, for example, you will see slight changes in resting heart rate. You'd see reductions across age and gender groups of about 0.2 to 0.4 beats per minute. That's sort of the typical change. But what you're seeing in 2020 over that same time period, it was actually a greater reduction in resting heart rate. So what was going on here? When we looked at the correlates of resting heart rate, what we saw was that actually the degree to which your heart rate changed was partially driven by whether you slept more. It also, was correlated with more activity. It was correlated with actually advancing with changes in bedtime. It was correlated with step count. And it was correlated with actually variability. So as your sleep became more highly variable, your resting heart rate went up. If sleep became less variable, your resting heart rate went down. If bedtime became more delayed, your resting heart rate actually went down. Same thing if your sleep duration increased, resting heart rate went down. And you actually see these effects through all of the different age groups. 65 and up is where they're the weakest, but they're still there for sleep. So this goes to show that even a small, subtle change in sleep duration and timing can have small and subtle but population-wide changes on a cardiometabolic risk factor like resting heart rate. Then we looked at the following months of the pandemic. This is when things started opening back up again. So what you can see here is the reduction. So if this is April, the sleep duration changes started reverting back to the mean in May and June, and in men and in women. So you can see like this effect may have been weakening over time. It would be interesting to see what happened after that as cases started spiking again and people started changing again. But that's what I got in terms of our data. I know there's a lot, and I went through it quickly, but I want to leave as much time for questions as possible. So thank you.
Thank you, Dr. Grandner. Do we have any questions? Would you care to hypothesize if there are any government policies that would be relevant to the pandemic, like changes from during that time, or specific situations in the U.S. that you think would be most related?
Well, I think the idea of working from home, reducing commute times, I think giving people permission to wake up later, allowed them to sleep in longer, and also gave them permission to go to bed at a time that was more conducive to them. So with all this talk of COVID-somnia, and I think the data showed that there's variability. Like some people were sleeping worse, and some people did have more problems. But for the majority of people who generally sleep well anyway, I think this was actually a beautiful mirror of the school start times data, where in the school start times data, when you give kids an inch, they take it. And so when you give them a little bit of extra time, they do sleep. They might not sleep in the entire extra time, but they sleep in enough where it makes a difference. And I think I'm just hoping we as a society learn from this, learn the good stuff out of this, and maybe learn how to give people more flexible time. I think that was the biggest driver, to be honest, was the degree of control people were able to have over their sleep.
Were you able to assess changes in WASO or sleep efficiency with the Fitbit?
So that wasn't present in the paper, but we did look at awakenings during the night. And what was interesting, there was a lot of variability, but we were able to see in line with the the months of the pandemic, as sleep duration was increasing, you didn't get to see sleep efficiency, but looking at WASO, actually awakenings increased on average, but it was highly variable. So it'll be interesting to parse out. So who had increased awakenings and how did that impact things? But yes, on average, awakenings did increase a little bit. How much of that was driven by increased sleep duration, which will generally increase arousals during the night anyway, and how much of it was a disturbance? Still looking.
So I know you didn't include any data past April in that particular paper, but I'll just say there's a lot of interest in continuing that longitudinal study. So
yes,
more work for you.
Yep.
But now a challenge question. Given correlations were low for changes in heart rate and sleep duration and timing, do you think this is clinically significant?
Yes, I think it is quite clinically significant for a couple of reasons. The correlations were low because there's lots of things going on, and because a slight change in sleep, I would not expect it to have a drastic change in heart rate, and it wasn't supposed to be an intervention. It's a natural experiment. And I think, and the change in sleep wasn't drastic. The fact that a mean difference in sleep duration of 10-ish minutes produced a measurable difference in resting heart rate that was reliable, even though it was small, it was quite robust. Which is why we have put the effect size in there, because the p-values were so crazily low, because it was pretty consistent. So it just goes to show that you have the law of large numbers in population level work, where it doesn't take a lot to make a big difference for a lot of people. You can either make a big difference for a small number of people, or a little bit of difference for a lot of people, and it can help improve life just a little bit. This just goes to show a small sleep duration change can have a measurable effect on a cardiometabolic outcome without even trying.
So I'm going to now mash together several questions, which you'll be coming because we've discussed this all the time. Please discuss the validity of the data using Fitbit compared to other actigraphy devices, its specific reliability and variability. And then finally, if you could comment on the use of wearables in studies. Does your study have evidence for confidence in their use?
Yeah, I mean, so one of my first mentors in sleep said the first 3 rules of science are know your measures, and know your measures. And I think that that's true in sleep, because there are no direct measures of sleep. Polysomnography is not a direct measure of sleep. It's also indirect. They're all indirect measures. They're all measuring different things. It's the parable of the blind people in the room with the elephant, and everyone has a different perspective on what they're seeing. It doesn't mean that one is correct and the others are incorrect. It's just you have to know the strengths and limitations of what you're looking at. Polysomnography would be great if you didn't care about what was happening in a real-world setting longitudinally over time. Sleep diary is great unless you're trying to capture things that people wouldn't have a perception of. Actigraphy is not great for things like insomnia, where it's about the measurement of difficulty. Neither is polysomnography for that reason either. So they all have strengths and weaknesses. Actigraphy has been in use for a long time. It seems to be, I would argue, that wrist-based, movement-based sleep tracking is probably the best objective real-world measure of sleep that can capture data over time. The Fitbit data, at least the devices here, were the devices that also used heart rate. And those are consistently showing to be as good or better than some of the research grade, even actigraphs, in terms of capturing sleep versus wake. I mean, look at the recent Chinoy paper that came out in Sleep, showing that the Fitbit data, and as well as other wearables, they're all in the same ballpark. There's probably a ceiling effect in terms of its ability to capture what a polysomnogram captures. But it looks like they're at least in the same ballpark, and nominally it actually performed a little bit better versus in sleep-wake detection. So I see, based on the data, I see no reason why not to use them as scientific tools, as long as you recognize what their limitations are. So one benefit in a study like this is, if you're worried about an individual device's variability, this is 150,000 people worth of data. If you're worried about an individual night's error, well, this is average data a week at a time, measured a month at a time. So you have, it's a fuzzy picture, I think, that is more true if you're worried about the snapshot being incorrect of the one moment in time. What we tried to do is use the strengths of this measurement approach and get around some of its limitations, because all measurements have strengths and limitations. There's my spiel. So in terms of should we be using them in research, I think this whole idea of commercial versus research grade is a false dichotomy. I think is it a device that's shown good performance in a research context? If so, then it can be used in a research context, recognizing its strengths and limitations. Where it's purchased and how much it costs should not be relevant in terms of its use as a scientific device. That's my 2 cents.
Excellent. Thank you, Dr. Grandner. I think we'll transition to Dr. Coiro now. If you could please share your screen. Looks good.
Great. Thanks for that introduction, Orfeu. So this is research that I conducted with colleagues at Loyola University, Maryland, as well as from Max Stern Academic College in Israel. So I wanted to acknowledge the contributions of the whole team on this study. So we collected data that come in both the United States and Israel to look at the prevalence of COVID-related stress, sleep problems, and mental health problems during very early stages of the pandemic, and specifically whether sleep quality mediated the association between these stressors and mental health. And we had a large enough data set that we could look at all of these data, both combined and separately by country, to see if we saw similar patterns across the 2 countries. Although I did want to say that as a clinical psychologist, for me, this is a large sample to have almost 2,000 people in our study. And it's very unusual now to have the smallest sample size on this panel. So it's a funny position for me to be in. So we collected our data last spring in May of 2020. And the Israeli data were about 3/4 of our data set and were administered in both Hebrew and Arabic online. And the American data were administered online in English, obviously. Both of these research teams were collecting other variables, and so I'm presenting on the sleep variables and the data that we collected in common, but both of these samples also included some other questions that I'm not presenting on here. In particular, in our American study, we were also focusing on strategies for coping with COVID-related stress that we're presenting in a different paper. So this is an adult community sample, and the average age, let's see what I want to say here. The average age of the participants was about 40, but the 2 samples were definitely very different. So although this isn't really the focus of my presentation, I just want to kind of remind the audience that the participants from Israel were significantly older, more likely to be female, and less likely to be employed, married, have children at home, or have a college degree or higher education. And also the racial and ethnic composition of the 2 countries is obviously very different. So all of the analyses that we conducted include controls for site or which country the data came from. So the measures that we used were a measure of 13 COVID-related stressors that was created for this project that included things like financial problems, canceling travel plans, difficulty completing work responsibilities. And the scores on the stress measure include both the number of stressors that the person reported as well as how stressful they perceived them or appraised them to be. We used the PSKI to measure sleep quality. PSKI is obviously a widely used self-report measure, but has some limitations because of the self-report nature of it. And I would echo what Dr. Grandner was just saying about sort of the pros and cons. We were able to get these data online early in the pandemic when people were home and weren't going to be coming into a sleep lab, but then there are the limitations of people reporting on their own sleep. And then we use the DAS to measure anxiety and depression. And I just realized actually during this presentation, that's the same measure that Dr. Yuksel's team presented on that they used to measure, I believe, depression and stress. So what did we find? First, we found that in both countries, 40 to 50% of adults reported stress related to finances, getting groceries, getting medical services that they needed, and taking on greater responsibilities at home or at work. And more than half of the sample reported stress related to social isolation or disconnection. And as you can see on the bars on the right, this was overall rated as the most stressful of the 13 stressors that we asked about. And since we collected this data, other research has now confirmed this pattern that social isolation and social disconnection are frequently emerging as being perceived as the most stressful aspect of the pandemic, more stressful than some of these more logistic or schedule-related stressors. Sites where the 2 countries were similar in terms of the prevalence of financial problems, but as you can see, other stressors that we assessed varied more by country. And I just picked 5 kind of high prevalence stressors here, but we did ask about 13 different COVID-related stressors and then combined them into a total stressor score. In terms of sleep, we found that in both countries, more than a third of adults said that the time that they went to bed or the time that they woke up had changed during COVID, since COVID started, or that their total hours of sleep had changed. And looking at the first 5 bars here, the specific sleep changes, at almost 90% of the sample reported at least one of these changes. So echoing the prior 2 presentations, that changes in sleep were very widespread. And interestingly and sort of unexpectedly, we found that the US adults reported more of every kind of sleep problem that we assessed than the Israeli sample, including that more than 80% of the American sample had what would be considered on the PSKI as poor sleep quality. And that pattern was also true for all 7 of the PSKI components, that the American sample reported more lower quality, poor sleep on all aspects of the PSKI. And then in terms of mental health, we looked at whether these community adults reported enough symptoms that they have a high likelihood of having a diagnosis in these areas. So were they above a clinical cutoff that would suggest that they might have diagnosable depression, anxiety, or an adjustment disorder? And again, clearly the US sample was experiencing much higher rates of these mental health problems than the Israeli sample. And then in analyses that I'm not showing here, but we presented in the paper, all 3 of these sort of major categories of variables were correlated as you would expect. So higher stress, sleep problems, and mental health problems were all correlated. So in the focus of this paper, we conducted multivariate analyses with many controls, including, as I said, controls for the 2 sites, to look at whether sleep quality mediated the association between stress, COVID-related stress, and mental health symptoms, and then also whether these associations were moderated by site. And so what we found here is that the mediated or indirect effect of sleep quality on both depression and anxiety was significant for both samples. So in other words, although these are cross-sectional data, our data suggests that part of the reason that COVID-related stressors contribute to more mental health problems is because those stressors affect the quality of sleep. And this pattern was found in both samples as well as for the combined sample. But as you can see in the numbers at the top labeled indirect effect, this pattern was stronger in the American sample. So there's a stronger mediating effect of sleep quality for the American sample than the Israeli sample. And the pattern was essentially similar for depression and anxiety. Here I'm only showing the results for depression, but we basically found the same pattern for anxiety symptoms. So what did we learn here? Although, again, these are cross-sectional data, our mediation model suggests that improving sleep quality may help people cope better with COVID-related stress and maintain resilience during what has become a prolonged pandemic. And we think that our data, like the others presented here, also support the importance of cross-national data. And I think that our results speak to both the importance of looking within countries and then also combining countries to understand both the global nature of this pandemic, but also I think it suggests some important questions about why participants from different countries might be coping differently and what cultural factors, such as perhaps historical experience of trauma, the importance of collectivism in the country, other factors like that might explain some of the differences that we see in these mental health outcomes. So thank you for your attention. I'd be happy to answer any questions.
So there was a workshop code posted. If hopefully that makes sense to everyone. You'll be able to get CME or other types of credit, I believe, after the conclusion of the presentations. We'd first like to take questions for Dr. Coiro, and then we'll open it up to everyone else. So a first one, did you find any association between sleep quality or depressive anxiety symptoms and post-COVID attention and memory problems? Do you have an extension to COVID-specific outcomes?
We did not assess any attention or memory problems. So the only mental health outcomes that we assessed are the ones I presented here, the depression, anxiety, and adjustment disorder using the 4-item World Health Organization measure. So no, we don't have measures of those cognitive problems.
So I will share that I've skipped some questions where I know the answer is you've not yet done that. And I think the weight of those many, many questions is how very interesting this type of work is with this new stressor that's affecting everyone and affecting people's sleep. Clearly has long-term potential follow-up research questions that could be asked, and there's a lot of interest in that in the questions. I'll ask the question again that was really to everyone, but this focused to Dr. Coiro. Did you look at how government policy changes or specific things during the pandemic associated with government policies or actions were associated with sleep health during that period you examined?
That's a great question. We weren't able to examine that systematically because we actually collected these data pretty quickly online. And so there weren't a lot of changes within the time of data collection. But one of the things that we were talking about as a team was whether some of the differences in the data, the findings for Israel and the United States had to do with the fact that in Israel, the lockdown was enforced much more stringently and systematically. So all of our colleagues who actually were in different parts of Israel during our collaboration were on a very strict lockdown. And as you know, those of us on the panel in the webinar who are American know, the lockdown was enforced very differently in different parts of the country by state, even by city and region. And so there's a lot more heterogeneity in terms of how much people were experiencing lockdown last May. So we wondered if that might account for some of the findings, but no, we weren't able to assess that.
Could I jump in there quickly? Just because I think there's so much similarities with what we did, and I agree completely with you that doing this cross-national analyses or collection of data, we could look at some things. And we also, as you saw, had a range of countries, and they did have different lockdown experiences. And we had one variable in the regression model, which did show that stricter level of quarantine was a predictor of worse sleep health. So it did suggest that there was something with the sort of the worse or the bigger lockdown could be having a sort of giving people a harder time with their sleep.
Whereas our data would really suggest the opposite, because the Israeli sample was definitely on stricter lockdown but had better sleep quality than the American sample. We do have zip code level data in our study. We've talked about maybe doing some state by state analyses where you could go back and look at what was happening with lockdown at that time, but we haven't done anything like that yet.
So there's many questions, but I think I'd like to transition to full panel questions. And so take this as you see fit. Was there a comparison of subjects who had COVID versus not in any of your data, or at least symptoms associated with changes in sleep? Was it too soon, really?
We have that question, but we haven't analyzed that.
I know that there's certainly a lot of interest in that now, as there's higher rates and variable rates over time in COVID symptoms, and also long COVID is now a large NIH announcement for long COVID studies.
Yeah, we did ask in our questions, but we had a small number of people who had been infected and said that they had had COVID, but that did not come out in the model as a significant factor. But also, I'm not sure, Dilara, if you want to just show that the last slide, if you like. So we are continuing with some of the research to look at long COVID, because I think, like we see with the questions, there is interest in that, and we agree that looking as well a little bit more at some of the sleep problems and fatigue that's coming out as a potential symptom in people with the long COVID. We're doing another survey. Again, it's a cross-national research collaboration, which I would say has been one of the greatest things of the pandemic. For us, at least, we've seen it's been a wonderful opportunity to collaborate with others that we never would have before. So we're doing this survey that's put there.
Great. So this will be available in the recording of this talk afterwards. A next question for the full panel. First, an observation. Changes in sleep are remarkably consistent across countries, cities, and studies, at least for this relatively early in the pandemic time period that each of you span. Later sleep-wake, longer sleep duration, but worse subjective quality. Now, there were some people with more shorter, so I might add variability to that increase. So any thoughts from the panel? Two things. One, which of these changes are desirable and which are undesirable? And two, what could be done to stimulate the positive changes without exacerbating the negative effects?
I would say my definition is based on our data. I would say what was desirable was slightly increased sleep duration and maybe slightly delayed sleep phase, at least for the people who chose to do that on their own, because it correlated with a positive outcome. But I do want to highlight that's also why we were looking at the variability data because, or the variability of the data, because the mean moved, but it didn't move for everybody. And it didn't even move for maybe 50% of people. It just moved way more. Like, for example, more people extended than restricted, and more people extended than restricted or did nothing. But it doesn't mean everybody extended. And I think the idea that, so sleep is universal. It's universally experienced by everybody. And the pandemic was interestingly also sort of universally experienced by everybody. And like sleep, I think it was experienced in different ways though. Just because I don't know that I've met a single person whose sleep hasn't changed at all as a result of the pandemic. But I don't know that everybody's sleep changed the same way. And I think it's important that just because a mean changed doesn't mean that everybody changed.
Other comments from other members of the panel? I do have
I would just second what Michael's saying, that there's the mean changes or differences, and then there's the individual variability. And I do think, again, we have this cross-sectional analyses, and we're trying to ask retrospective, how is your sleep compared to before? And then we do see there's definitely a portion whose sleep is worse, and that goes along with, like Michael says, the worse outcome. And in this case, we focusing a lot on the mood and more depressive symptoms. I think as time has gone by, we are seeing now more of the longitudinal analyses coming out, which I think is great, where we can see how did sleep change and go along with changes in mood over time. And I think that's just something to look out for. It's not over yet in many parts of the world as well, unfortunately. And not only is there the potential for long COVID impacting sleep, but there's also this very long tail of mental health problems. And I think that we're all saying in our portions of the data, there's a significant number who are having really poor sleep quality and insomnia symptoms. And I think that's going along with a worsening of mood. So it's the longer it goes on, it's sort of, let's hope it doesn't have this prolonged negative, long lasting.
And that might also be part of the delay. Part of the phase delay might also be difficulty detaching at night and trying to figure, watching the news and seeing the numbers. And so the delay might not also always be a good thing either.
If I could move to a next question. We have this detrimental sleep patterns in some, and that the pandemic is not affecting everybody poorly. What evidence do each of you have for disadvantage or mental health conditions or lower socioeconomic status or other sources of disadvantage, underrepresented minority, as being more impacted by the pandemic in terms of sleep health? Could each of you reflect as you wish on that? Dr. Coiro, would you want to start? Or?
Sure. We have not looked at that in relation to sleep health. In another paper that we're working on from the same data set that's under review now, we've presented data showing that people from underrepresented groups in the United States, including adults who identify as Black and Hispanic or lower income groups, report significantly more COVID stress, more depression, and more anxiety. So our data are really supporting differential effects of the pandemic, and sort of, which we would argue would point to differential need for interventions and preventive measures, but we haven't looked at that in terms of sleep, which we could do. That's a great question.
Others?
We didn't have those data. Fitbit doesn't collect those, so we don't have them.
Probably good. Dr. Yuksel.
Yeah, we did look at the country income classification. So we saw a significant association between actually a better sleep health and a higher country income classification, which in turn also means that a lower income classification is associated with poorer sleep health. So we did find some correlations here in our study.
Another source of potential strain, some of you covered this before, but the next question asks from a family system perspective, calling out the special issue. If you have a family systems sleep paper, there's a special issue call, and those are due at the end of June. Please consider and be in touch if you have questions. But from a family system perspective, would you consider change or variability in sleep as it relates to some family characteristics as being present in your data, like kids at home, how many people work from home versus not? Any of you have evidence on that?
We did look at, we were a little surprised. I mean, from our personal perspectives, we thought that maybe people with really young kids would have worse sleep, but that did not appear. But we did see that people who had more difficulties working from home, like transitioning from working in the office to working at home, had poorer sleep.
The new density, how many Zooms in one household? Another good challenge question for Dr. Grandner. How accessible is the Fitbit data, and are there limitations on how much data we have access to if not partnered with the company?
I don't know, and I don't know, but no, really. So Fitbit, for good or bad, the reason I was able to get a hold of this was because of being able to partner with them. I had no access to the raw data. They guard their raw data very carefully. When I asked them about it, they see it as a privacy issue, as a safety issue. They don't want people's data. They want people to be able to trust their platform. They don't want people to feel like people are going to figure out who they are based on their private data. So they're very guarded about it. But they are open to. They're very open to asking these sorts of questions, and so. I guess, and they've been increasingly open to research. They have a portal now where researchers can apply for to reach out to them in terms of research questions, whether it's getting devices for free or at a discount, or partnering with some of their data scientists to look at some of their data. I can't speak for the company; I don't work for them. But what I can say is that at least regarding this, they were pretty open about. Being able to, this is what we've got, here's what we can do, whatever we've got, let's see what we can use it for, I'm using it for good. So they don't have, they probably won't give you bunches of raw data to look through, but I think they're increasingly open to partnering with researchers to answer these questions that they now have the ability to do with some of this big data.
Thank you. So there's I'm not getting to 80 or 100 questions, so thanks everyone for your interest and enthusiasm. I'm trying to do the best with a very fast scrolling window here. Somebody asked a question, and I'd like to broaden it and ask each of the panel members about what you see as the most important future questions, extensions of this work. But their question was sort of a comment or sort of great suggestion. Are there any plans to do class analyses to see if there are sleep profiles that differentially associate with health outcomes, and I would add over time? So maybe taking that question as a lead-in, could each of you say what you think are the most important things we in sleep health should be looking at going forward as this pandemic continues to roll across the world? Could I start with maybe Dr. Baker?
Sure. I think, so again, I keep coming back to ours was cross-sectional, and it did depend when we collected the data. So in our case, it was late April, May, and countries are in different stages. And I think that what we want to see is you might expect there to be everybody's sleep is affected, at that time because it was this world shock. And then some people, the persistence of the trouble sleeping, I think, is what we want to track and look at. And so the people who continue to have the insomnia symptoms and the trouble with their sleep, which goes along with their mood symptoms. And I think also looking at different groups. So I think we're seeing in some other studies where we're looking at longitudinal data in teenagers, and we haven't spoken about them very much. We've focused on adults. But I think just determining subgroups who may be more susceptible or more vulnerable, and especially looking at this persistence over time of insomnia symptoms, because we know that's a strong predictor of later mood, sort of long depression and other mental health outcomes.
Thank you. Dr. Yuksel, would you like to comment on what you.
Yeah, I totally agree with Dr. Baker, and I think we should also, especially besides, looking at the bad outcomes, also look at the good outcomes and see, what is actually better now and how can we maybe, learn something from all of this and how can we transition or transfer it to the future? Because this is, the first time that actually maybe people are allowed to sleep how they want. They are not dictated maybe that much from outside, from commuting issues, from, having to be in the office at, 7 a.m. or so. So let's, take advantage of that and find something good.
Thank you. Insightful. Dr. Grandner, briefly?
So I think, at least from the perspective of these data, yes, I think profiles will be great. And in particular, what can we get out of these signals, especially in large numbers of people, that might be novel sort of outcomes and metrics that leverage the strengths of these data. I just want to echo, how do we learn from the good and from the bad in terms of what's happened in this natural experiment and move forward from that?
Dr. Coiro.
Yes, I think I would agree with the other speakers that I think I'm really interested in patterns of both resilience and recovery. And the data set that I presented here, we were not going to be able to follow up with this sample, so it wouldn't be from that data. But I think it would be important to identify, resilience, meaning sort of who's maintained good health and mental health the entire time. What are the characteristics of those people from the beginning that they were able to kind of weather this pandemic with health? And then also, who are the people that recovered that maybe early when we collected our data, they didn't look like they were doing that well. Now they are doing well. And how did that happen? What were their characteristics? I told you I'm doing another study about coping strategies. What are the things that we can learn about how to cope with these stressors that help us recover quickly?
So
I really want longitudinal data to look at that.
So thanks again to all of our sleep health experts. Thank you for your interest in sleep health, and we'll see you again on a future webinar.
Thank you.
Have a great day.
Thank you. Bye-bye.
Thank you.